Hey folks, it's me, your host Jason Coggins again. We're back for another sketch session. In today's episode, we're going to be talking about the lateral collateral ligament of the knee. We're going to talk about the anatomy, the function, what a patient might look like in the clinic that has an LCL injury, what you might expect to see on physical exam, and how to treat it. So I trust that you will find this segment useful and that next time you see a patient in the clinic with a suspected LCL injury, you will be able to treat it more confidently. So let's get started. Prior to this, I've already reviewed the ACL, or the anterior cruciate ligament, and the medial collateral ligament. I'll be doing the posterior cruciate ligament as well in a separate episode. But the lateral collateral ligament of the four main knee ligaments is, in isolation, generally the least injured. And that is just due to the mechanism. So let's get started with a bit of the anatomy. So we'll draw our generic knee. And this will be a representation of a left knee, because our fibula is on the outside. So we've got our femur, tibia, our patella, and our fibula. So the lateral collateral ligament originates from the lateral femoral condyle and attaches to the proximal aspect of the fibula on the fibular head. So as I've discussed in previous videos related to other ligaments, just looking at an attachment point and an origin point of a ligament, that tells you what its purpose is, what its function is. And if you look at the attachment points for the lateral collateral ligament being on the femoral condyle laterally and the fibular head, what this tells you is it prevents those endpoints from separating. So it prevents a Varus type of force. So it prevents the tibia from going inward. And if you force it, it's going to stretch that ligament, the lateral collateral ligament. So what is the function of the the lateral collateral ligament, the LCL function? To prevent excessive Varus force. So if you know what its function is and you know its anatomy, so how does one injure it? Well, the mechanism of injury, or MOI. Mechanism of injury for a lateral collateral ligament would be an excessive force that is Varus, so an excessive Varus force that exceeds the strength of the LCL. How would that happen? What's an example? A football running back running the ball down the sideline, he's breaking away, and a speedy defender comes running from an angle and dives in front of him to catch his legs and hits the inside aspect of this left knee. That would cause his knee to go outward and the tibia to go inward, and that would create an excessive force on that lateral collateral ligament. So the history that you will typically see for an LCL injury, which again of the four ligaments is the least common. So in my career, it is most frequently seen in as a sports injury, usually a direct blow to the inside aspect of the knee. Direct blow to inner knee. But you can also see this with a fall from a height. You have to worry about concomitant injuries, multi-ligament injuries, fractures as well. But again, an isolated LCL injury is rare. So for the history, they have the mechanism. Frequently they will feel a pop if it's a complete injury. There generally is not an effusion, and that's because the LCL is an extra-articular ligament. It's not inside of the knee joint. So that's just a little pearl. It's extra-articular. but they would have some superficial swelling laterally. The swelling is isolated lateral. They may or may not have trouble weight bearing, and if it's significant enough, they may have instability where the knee wants to buckle outward. So what would an exam consist of for a lateral collateral ligament injury? So lateral swelling, they'd be tender to palpation, which is TTP, over the lateral collateral ligament. Now, if it's a complete rupture, you may not be able to palpate the lateral collateral ligament. Typically, an uninjured or an intact LCL will be a nice taut rubber band pencil-like structure on the lateral aspect of the knee near the posterior portion of the joint line, particularly when the knee is flexed and the hip is externally rotated. So if you have a person cross their legs or cross their, say, right ankle over their left knee, you would be able to palpate along that lateral joint line, and as you get closer to the posterior portion, you'll palpate a nice taut band, and that is the LCL. But if there's a complete injury, you may not palpate that. If it's a partial injury, they may just be tender there. So the special test for the ACL is, or correct myself, the LCL is the Varus stress test. And that test is where you will place one hand on the inner aspect of the knee along the medial knee. You'll push outward or either simply stabilize the knee from the inner aspect, and you will push the distal tibia towards the midline of the body. So you'll be pushing the knee in an outward direction from midline. And you'll want to do that at 0 degrees of extension and at 30 degrees of flexion. And that tells you two different things. An isolated lateral collateral ligament injury will only be unstable in 30 degrees of flexion. If it's stable in 30 degrees of flexion, they still could have an injury. It would just be to a lesser degree. Typically they're graded 1, 2, or 3. And that can be related into how much you're able to open that joint space. If it's around 1 to 5 millimeters of opening, that's considered a grade 1. If it's 6 to 10 millimeters, that's a grade 2. Anything greater than 10 millimeters at 30 degrees is a grade 3. So again, if it's stable at 0 degrees and lax at 30 degrees, that's an isolated lateral collateral ligament injury. If it's unstable at 30 and 0 degrees, then you're looking at a more significant injury. You could still have an LCL tear, but there's usually other associated structures injured, whether it be the ACL or posterior lateral corner. But for the purpose of this presentation, we're focusing on the lateral collateral ligament. So we have reviewed the function of the LCL, typical mechanism of injury, an LCL injury history, and exam. So, LCL imaging. Well, plain radiographs, you won't really see anything unless there's an associated fracture. So, X-ray is typically negative. If you are concerned for anything more than a grade 1 injury, an MRI is the imaging study of choice. And so greater than grade 1, get an MRI. And that would tell you if it is complete or partial injury. So you've diagnosed it now with MRI. What would be our treatment plan? So I want to speak of this really in terms of not in an orthopedic clinic necessarily, but more in a primary care or urgent care type of setting. So you want to, for initial treatment, you want to protect it. So how do you protect it? You'll protect it in a hinged knee brace that gives that knee support and prevents any varus stress. So depending on the severity, it can be a smaller or shorter hinge knee brace. If it's more significant, you can use a telescoping range of motion brace, but a hinged brace nonetheless. Crutches if need be, if you're worried about the patient falling. So plus or minus, PRN. Treating the initial injury itself with your typical RICE protocol: rest, ice, compression, elevation, NSAIDs, and or non-opioid analgesics. And refer to ortho, definitely for grade 2 or 3. For most LCL injuries that are grade 1 and grade 2, particularly if they're isolated, these can be treated conservatively with what I've outlined here, plus a bit of PT. If it is a grade 3 that is a complete tear and there's instability, that likely would require surgical intervention, which I will say grade 3 would likely need surgery. So that wraps up my review of the lateral collateral ligament, including the anatomy and function, the mechanism of injury, a person presenting with LCL injury history, the exam, initial treatment, and I'm not getting into definitive surgical procedures. That's out of the scope of what I'm aiming to do. But I hope that you have found value from this. And again, the LCL is the least injured ligament of the knee, but you certainly need to know when to expect, or not expect, but to suspect a lateral collateral ligament injury. All right. So that concludes our segment on the LCL. I trust that you have found it beneficial and that you will know what to look for the next time you see a patient in the office that may have an LCL injury. So if you have found benefit from this video and the other videos I've put out, I would be very grateful if you would subscribe by clicking the link below. And you can check out other videos up here and here. So again, I have thoroughly enjoyed making this video for you, and I look forward to doing more. Have a great evening.